Hi, my name's Ian Battersby. I'm one of the internal medicine clinicians at Davies Veterinary Specialists, and today is our final webinar in our antibiotic series. And the subjects that we're going to cover today just tie up some loose ends, and we're going to cover things like duration of therapy and touch a little bit on pharmacokinetics. So, first slide, we're moving into talking about treatment duration. And as you'll remember from, I think it was the second webinar, we used the cartoon graphic of an antibiotic influencing the population of bacteria. And if you use a broad spectrum antibiotic, you can start eliminating bacteria that you don't want to target and ergo essentially select for resistance. However, there's two components to that. There's the spectrum of activity of the antibiotic, but how long you use it for. So the longer you use it, the longer you're putting that selection pressure on the bacterial population. So one of the important things really is that we need to reflect on how long a course of antibiotics is ideally needed in a condition. And in an ideal world, we want to just use enough antibiotic to eliminate the problem and then stop. So to highlight this, we're going to talk a little bit about some of the typical duration of antibiotics prescribed in different conditions. And sometimes if I'm doing this to an audience, I'll ask for a show of hands on these routine conditions that you may diagnose in your practice. So the first one will be an uncomplicated bacterial cystitis in a female dog. And the second one would be a pyelonephritis, again, let's say a dog for argument's sake. So thinking about whether you typically prescribe a 5-day course, a 10-day course, or a 2 or 3 week course. And when you look at the veterinary literature, certainly for pyelonephritis, a lot of the veterinary textbooks recommend a 4-week course of therapy. Now, if you look at the human literature, there's a lot of interest and a lot of work in this area now. Looking at how short a course you can use to resolve a condition, and looking at large multicentric studies and reviewing them, such as the Cochrane Reviews that are published. They're able to come up with recommendations, and this slide here just highlights some of the Cochrane recommendations for some of the conditions that we've just thought about how long a duration of therapy we might prescribe. So admittedly, these are different species. We're not talking about a dog, we're talking about humans. But in an uncomplicated urinary tract infection, the Cochrane Review showed that there was no difference in using 3 days worth of antibiotics versus a 5 to 10 day course, which is quite a significant difference in duration of therapy. Again, looking at pyelonephritis, in non-hospitalised patients, there was no difference between a 7 to 14 day course versus a 14 to 42 day course. Now, that's based on a lot of evidence and a lot of reviews. The challenge is in the veterinary literature, there's not a lot of papers to back up these modifications of therapy duration. However, a lot of the treatment durations that we use are typically extracted from human medicine. So when you scan the literature, there's a lot of papers out there on a variety of different things, but on duration of therapy, there's not a lot out there. This was a study published a couple of years ago that compared 3 days worth of a fluoroquinolone and 14 days worth of amoxiclav and compared the successive outcome. And this paper showed that there was no difference between the 3 days of fluoroquinolone and 14 days of amoxiclav. Now, that's great because that shows that it's a shorter duration of duration of therapy that was required. However, it was using 2 different antibiotics. What I've been really interested to see was the effect of 3 days of amoxiclav versus 14 days. That would have been really powerful information for us. And I think this is an area that there's a lot of opportunities for vets working in different areas of practice to look at this area and reevaluate duration of therapy and hopefully perform studies. I've been in contact with some first opinion practitioners and working together, we've been able to come up with some observational studies looking at the impact of shortening some of the courses of antibiotics they prescribe for some quite common conditions. So it's a fantastic area for us to look at and potentially make quite a big impact on antibiotic usage. So a few of the little areas I just want to tie up the webinar series on is firstly, just referring to cultures and sensitivities, and you may remember we've mentioned that a few little times. That's one of the things we tend to focus on. Is when we get the resistance profile through, is the antibiotic effective against that bacteria? And I suppose it's important to highlight that the culture on the plate is challenged against what we would predict would be the antibiotic concentration in the plasma. Now that might not necessarily be the case in your target area. So that's why it's important to make sure all of the factors are optimal, such as blood supply to the area, draining pus from areas where you want the antibiotics to work. So there may be opportunities where you've got a resistance on the plate, and if that is using a antibiotic concentration that you'd expect in the blood, there are other ways around it using the pharmacokinetics strategy to reach higher levels. So resistance on the plate doesn't mean it's not going to work, it just means at that concentration the antibiotic won't work. So a couple of those ways that we can manipulate that situation. First is looking at the pharmacokinetics of beta-lactams, so this will be cephalosporins and penicillins. What we know is that the way that these drugs are filtered, they can reach 200 times the concentration in the urine than what you will in the blood. So if you have a bacterial infection in the bladder, the concentration of that drug is going to be much higher than what you're getting on the plate. It's always good to check with the lab what concentration they're using on the plate, but if they're using plasma concentrations, then with a amoxiclav or with a cephalosporin, you're going to achieve much higher levels of antibiotics, and you may be able to overcome the resistance that is perceived on the plate. The other way that you can do this is by looking at topical therapy. So again, topical therapy can reach much higher levels of the antibiotic in your target area, and I guess the area where we commonly do that is ears, for example. And the other advantage of using topical therapy is that it's only targeted against the bacteria that you're interested in, so you're not going to have that selection pressure on the other bacteria in your body, for example in the bowel. The final thing I just want to mention is spectrum of activity. Again, referring back to that, that simple cartoon model we used, the broader spectrum the antibiotic or the combination of antibiotics you're using, the more impact you're going to have on potential non-target species and select for a resistant organism. So it's hard to do in some situations because the number of antibiotics we've got available in veterinary medicine are quite limited, in that there's not that many that are narrow spectrum. I guess the best examples would be aminoglycosides or metronidazole, only affecting anaerobes. But a way that we can one way that we can modify the spectrum, the broadness of the spectrum of activity we use, is not using combination therapy. So, trying to use one antibiotic rather than just in case using 2 or 3 at the same time. That will naturally narrow the spectrum of activity. The other thing that I should mention is, there are a number of antibiotics in human medicine that are kind of kept behind a glass cabinet. They're kind of the last-ditch attempt for some of these very resistant, multi-resistant bacteria. Some of those drugs are vancomycin, imipenem, and I guess as veterinary surgeons we should reflect whether we should be using those antibiotics in our patients. Certainly not routinely. They certainly should only be used as a last resort, and there are potential strong arguments that we shouldn't be using those antibiotics at all. So that concludes the last webinar of our antibiotics series. I hope it's been useful and informative. We have got plans to do other webinars on other subjects, so keep an eye out for those, and take care.